morning, dear colleagues, dear friends, ladies and gentlemen. It's my pleasure to welcome you to 28th edition of Prague Rhythm. And I would like also to thank to organizing organization CCL, and namely to Hanna Klimentova for organizing all this logistics around. And obviously, I would like to thank to our sponsors. You have a list of sponsors in your program, and it will be projected also here during the cases. So without their help, it would be impossible to do this meeting. Would you like to add something for beginning, Peter?
Actually, I love to be here. I love the name Prague Rhythm, but it's still workshop, okay? Because the name of workshop means that we are active. And I love this overview you showed now, because the overview indicated that this is 28 very hardworking events. And I think it's about it. So full time, like 3 days, consecutively 3 days, we are working, and we are showing how we are working and how we can increase and how we can decrease our effort, and how we can enjoy and show how we can help the patients. And helping the patients is the main mission for us. And actually, the electrophysiology is really the highly dynamic subject in the cardiology and the medicine. Actually, for tomorrow, please, guys, we started very early. So we are really proud to show you very high number of cases tomorrow. So please awake early, okay?
Set your alarm clock early.
Okay, it's your turn. Thank you, and welcome here.
Thanks, Peter. I have a couple of slides. Just this one I show always. This just to remind you these humble beginnings in 1998, 28 years actually ago, or 29 years ago, but we skipped one meeting during COVID. And it was initially just for Czech and maybe Slovak physicians, but from the second year, there were more foreigners and more international forum than at the beginning. We started in IKEM, then we joined in 2008 with this guy, and we ran it from that period until now. So we will show a new concept of echo imaging by Ante Anic. Carlo Papone will not be here, but he will talk about immune system and cardiogenetic diseases via Zoom. And then we show a lot of pulse field technologies and strategies, also PVI plus left appendage closure, and some strategies of cardio-neuroablation, which became over time strategy of choice for many patients with functional bradyarrhythmia. So I don't need to talk about this. You will also see some pulse field cases in ventricle. Why pulse field in ventricle? Because it can probably penetrate better through the scar, and Peter Peichel will show you some of these cases. But namely, we will focus on atrial arrhythmias because that's our main job today, and you will see a lot of new technologies for PV isolation or PV isolation plus strategies. Again, reminding you that there is no one entity of pulse field. Each pulse field has to be tested and looking for safety and efficacy. So it's not like RF. I would like also to remind you that during this meeting in 2015, we showed the first worldwide live case of neuroablation. I'm so overwhelmed by pulse field that I made a wrong title. It's neuroablation, not pulse field ablation. Sorry for that. And a few words about Czech registry. As I mentioned already, We have probably the longest living registry worldwide because we started in 1994. Robert Čihák, who is present here, he presented at that time first experience of 4 centers in Czech Republic with ablation. And then we run this registry under different administrators. And today we fused with UZIS, which is a statistical department of Ministry of Health, and we will have data also from insurance companies, so we could look at mortality, complication rate, hospitalization, length of hospitalization, redo cases, things like that. So we are at the very beginning. And I have just a few slides from this new registry. We still have 25 centers per 10 million inhabitations, and then we have regional distribution. Obviously, Prague and Brno, there is the highest concentration, and you see that there is increase in the number of procedures, but not that profound like in 2024, where with the advent of pulse field, there was 18% increase against 2023. These are procedures per center. So you see that it's now getting, to higher numbers, like TriNet, which is the 3rd in a row. They did already more than 1,000 procedures. Some centers doubled the number of cases from one year to another just because of pulse field. This is demographic. You see that majority of patients between 70 and 74, but we do also octogenarians, and we do obviously younger patients. This is a very important slide because it shows, and it's surprising because if I see from different centers and different studies, males are very predominant in AFib ablation, but here you see it's almost 50-50 with women, and obviously some arrhythmias like AVNRT are typically occurring more in women. But also idiopathic VPBs and VTs are more prevalent in women, and some other arrhythmias are just 50-50. Your AFib ablation is absolutely dominating. Every year it's increasing the proportion, and then atrial flutter is typically on the 2nd place, and 3rd place is AVNRT. Accessory pathways stay around 3% or less than 3% today. And you see that the number of persistent cases is increasing, so it's almost, again, 50-50 with paroxysmal. This is interesting. You see that energy for AFib ablation particularly, this is for AFib ablation, 93.3% of ablations in Czech Republic last year were done with pulse field technology, RF only less than 6%, and there is practically cryo died in this country for AFib ablation. Many people use no mapping system, especially if you use Farapulse technology. You don't need mapping system, but electroanatomical mapping in total is about less than 15% of cases. And ICE is still quite prevalent for AFib ablation, about 40%. And obviously all access is endocardial predominantly. And in terms of catheter type, no wonder that multipolar catheter is dominating because it's dominating pulse field. This is a slide from partly from this atlas of EHRA, showing that the Czech Republic was in 23 on, I think, 5th place in a number of AF ablations per million. If you look at pulse field ablations in 23, we were absolutely dominating. Obviously, this is not the case today, but we were one of the countries which early adopted this technology, and that's basically mainly thanks to Peter and his team, who were pioneers in use of Farapulse technology. So I will finish with this quotation by British author Lewis. There are far, far better things ahead than any we leave behind. So we are looking forward to to see further development of strategies of ablation and improvement in pulse field technology. So thank you very much for your attention, and welcome again. And now, just to set a proper rhythm for the meeting and also to synchronize our heartbeat, we will enjoy a short musical matinee by two young Czech artists, Terezia Hledíková, violin, and David Pejruška, cello.
Good morning, ladies and gentlemen. Thank you for having us. My name is Terezia, and I'm a freshly alumni of Academy of Performing Arts in Prague, and my colleague David is just finishing his bachelor degree there. We prepared quite a rich program for you. We will start with Reinhold Glier and his Gavotte. Then we'll play Alessandro Rolla and his Andantino, and we will finish with Zoltán Kodály and his first movement of duo for violin and cello.
Terezia Hledíková and David Pěruška. So now, ladies and gentlemen, we will continue with an overview of cases from a previous year. Don't worry, we don't have delay because I decided to skip my presentation in general session, so we will be pretty in time. And it's my pleasure to invite our fellow from IKEM, Kazuto Hayasaka, who is obviously Japanese, as you can identify. And he will give us an overview of cases done in IKEM last year. Kazuto, please.
Yeah, thank you, Professor. Good morning, everyone. My name is Kazuto Hayasaka, an AP fellow in IKEM. It's a great honor to present the overview and the follow-up of the last year's cases today. The first case was ablation of ischemic VT by the lattice tip catheter. The patient was 75-year-old male with ischemic cardiomyopathy. He experienced a posterolateral myocardial infarction in 2005, and he underwent 2 PCIs. And his ejection fraction was 30% with aneurysm of the posterior and the inferior wall. And the substrate map showed the extensive posterolateral to inferior wall scar, and 3 non-tolerated VTs from there were induced. So substrate homogenization was performed. And in this case, we present the interesting concept of the lesion durability that capture loss during PF ablation may indicate a more durable lesion. And a total of 86 PF applications were applied, and a VT thought to have epicardial exit was still induced, but the procedure was concluded. However, so far, only 2 non-suspectees have been recorded by the device. The next case was substrate mapping and VT ablation using S3 protocol and guided by CT imaging. The patient was 74-year-old male with ischemic cardiomyopathy. He experienced the inferior wall myocardial infarction in 1989 and 2019. And he underwent surgical revascularization, and his ejection fraction was 30% with a kinetic inferior wall. On S3 maps, 2 dense color areas match thin ventricular wall regions or border zone on CT, and S3 delayed potential sites, you can see here, showed mid-diastric potentials during the VT. Therefore, 2 VT critical isthmus sites on the septum were modified, and late potentials were eliminated. And the BBL VT was also induced, so right bundle branch ablation was performed as well. However, in this match, multiple ATP therapies occurred, leading to a repeat PFA session. During the procedure, 4 scar-related VTs involving the lateral, not septum, lateral to inferior wall were induced and modified with PFA. And since the ablation, no recurrence has been observed. The next case was paroxysmal AF ablation with variables. The patient was 54-year-old male diagnosed with paroxysmal AF in 2023, and echo was normal. And a PVI using varipulse was performed, and for PVI, 4 applications were delivered per PV, 2 inside the PV and 2 at the antrum. And during the procedure, ICE confirmed a good PV count. ICE confirmed good catheter contact to PV, and microbubbles were observed. But of course, according to the INSPIRE study, as Dr. Grimaldi said, MRI showed no cerebral infection. And the PVI was successfully completed, and no events have observed without any AEDs. And the next case was paroxysmal AF using a FARAPulse and ICE. The patient was 61-year-old female diagnosed with paroxysmal AF in 2024, and echo was normal. In this case, we demonstrated the utility of ICE imaging. ICE from the RVOT allowed clear visualization of the separation between LAA and LSPV, and also ICE confirmed good contact with the large ostium of the common LPV. And accidentally, fluoroscopy initially suggested the RSPV, but the ICE identified it as the middle branch. And PVI was successfully completed, and no events have observed. The next case was ablation of paroxysmal AF using Fowler pulse guided by rotational angiography. The patient was 61-year-old male diagnosed with paroxysmal AF, and his echo was normal. During this procedure, a 180 degrees left atrial angiogram was reconstructed into a 3D model and overlaid on fluoroscopy to guide the procedure. And with this guide, PVI was successfully completed, and no events were observed without any AEDs. The next case was ablation of persistent AF using Cryobron Arctic Front Advanced Pro. The patient was 69-year-old male diagnosed with persistent AF in 2021, and he had experienced 4 cardioversions, and his echo was normal. In this procedure, PVI and roofline were performed, and for PVI, PV potential elimination was confirmed during cooling, and for roofline, good contact was confirmed by ICE, enabling cryoballoon ablation. And the procedure was completed successfully, and the patient had no events so far. The next case was ablation of post-ablation AT using a Affera system. The patient was 74-year-old female diagnosed with persistent AF in 2019, and she underwent surgical ablation, including PVI and box isolation in 2020 and catheter re-ablation in 2021. However, she experienced a high symptomatic recurrent AT in 2025, leading to a repeat session. Her ejection fraction was moderately reduced with 45%. During the procedure, despite 2 prior ablations, the LIPV and the posterior wall showed reconnection from here, but this was passive. The clinical AT was anti-clockwise flutter, actually. So PVI and box re-isolation were performed. PFA delivery at the anterior aspect of the RIPV completed the PV and the posterior wall re-isolation at the same time. And for CTI, AT terminated with the first RF application, and the CTI block was completed after 3 RF applications. And then AT rotating around the LA anterior wall was induced as well, and an anterior wall line was created with RF. And since the ablation, no events have observed without any AEDs. And the next case was cardioneal ablation guided by ECVS and facilitated by CT imaging. The patient was 44-year-old male who was hospitalized for 2 episodes of syncope and sinus arrest of 5.4 seconds on the EKG and cardioneal inhibition with a long pause on head-out-chest test were documented. In this procedure, CT-derived epicardial fat containing GPs were merged with Carto, and ablation at these sites eliminated AVS-induced sinus arrest and AV block. And sequentially, ablation of superior perceptor GP and inferior perceptor GP from both left and right atrium was performed, and the patient has had no further syncope since the ablation. And the last case was anatomical cardioneal ablation for cardiac inhibitory syncope. And the patient was 26-year-old male with recurrent syncope, and a 10-second sinus arrest on head-up-chest test was documented. In this procedure, we compared the anatomical ablation sites with the CT imaging, and for superior perceptor GP, CT-derived epicardial fat was located superior to the ablation points, possibly due to segmentation of epicardial fat in the transverse sinus. And for inferior pulseptal GP, ablation points overlapped with the epicardial fat region. And after the ablation of superior pulseptal GP and inferior pulseptal GP, the patient has remained free from syncope. Thank you for your attention.
Okay, and the next overview from the last year, from whole cases, will be presented by our fellow Katka Kenarji. You can distinguish that she is by origin Bulgarian, but probably we cannot see that, right?
So, good morning, ladies and gentlemen. My name is Kateřina Kenarjevová. I'm from Cardiology Clinic, Homolka Hospital. Let me introduce the live cases review from 2025. We enjoyed 10 live cases, 7 AFib ablations, 2 VT ablations, and 1 left atrial appendage occlusion. So let's move to case number 1. You see EasyPulse catheter. This is first check ablation catheter. We use it for 47-year-old man for paroxysmal atrial fibrillation. It's over-the-wire compressible mesh catheter. We can use 3 geometry, Olive for lines, basket for PV osseum, or disc for PV antrum and postural wall. PF train duration is 10 seconds. And be careful, no rotations are needed. In this picture, you can see a beautiful view on X-ray with catheter, and you see that EasyPulse catheter is in the inferior pulmonary vein. The next picture shows us index procedure post-ablation map. After 2 months, we remap, and there were no gaps. And the follow-up was no AFib recurrence. So let's move to case number 2. It's about FARAWAVE NAV, 31 millimeters, which is integrated with Opal HD mapping system for real-time 3D visualization. The catheter has 5 spines with 20 electrodes that can switch between basket and flower shapes to suit different anatomies. We used it for 48-year-old man with paroxysmal AFib. And you can see the beautiful pictures. There are filed tags and catheter shadows. We made PVI and we ablated on CT isthmus. After 6 months, there was no recurrence of AF and the patient was very well. Let's move to case number 3. We used FARAWAVE. Everybody know this catheter. It is the most beautiful catheter in the world. And we use it for 33-year-old men for paroxysmal atrial fibrillation. But this is a different case because we don't use eyes. This case was made by German electrophysiologist, and it was only fluoro-guided. You can see transeptal puncture with no eyes. We made PVI only, and after 6 months, there was no AF recurrence. Case number 4, it's OptiShot catheter in Vision AF study. We use it for 61-year-old man with paroxysmal atrial fibrillation, and as you can see, it's ultra-compliant balloon with direct endoscopic visualization. It delivers circumferential lesions to the target veins all at once. And as you can see, we see beautiful balloon in X-ray picture. This is the after ablation map, and what is surprising, after 3 months, we made persistent effect. Let's move to case number 5. It's about self-fixed system. It's only 1 nanosecond pulse field ablation catheter with 11 French catheter and bipolar electrodes. The ablation is very short, for 5 seconds, and pulse field is generated between the two large rings electrodes. We use it for 55-year-old woman with very symptomatic paroxysmal atrial fibrillation. As you can see in the beautiful picture, we see the catheter shadows, and you see that there is a common pulmonary trunk on the left side. After we remapped again, there was persistent effect, and after 12 months it was very nice, and there was no recurrence of atrial fibrillation. Case number 6, pulse select catheter. It's the catheter with it uses bipolar biphasic PFA to cause irreversible electroporation. It's electrode array, and you know that there is 9 gold electrodes used for pacing, sensing, and ablation. We use it for a 52-year-old man with paroxysmal atrial fibrillation. And again, after 1 year, there were no symptoms, no AFib recurrence, so the effect was very good. Let's move for the last case of atrial fibrillation. It's case number 7. It's about field medical catheter, which is associated with PFA. We used it for paroxysmal atrial fibrillation to 69-year-old woman. It's the technology which is field bending technology, and it uses point-by-point PF ablation. There is focal contact sensing and sub-second waveforms. And this is the remap during the procedure. And after 6 months, we were very successful. There were no recurrence of AF. Let's move to left atrium appendage. This is conformal left atrial appendage seal. This is the study class. It is a single-arm study. It is a prospective study for non-valvular AF. As you can see, this device has a dynamic conformability, and it's made by biocompatible photometrics, and inside there are anchors. As you can see in the picture, before the procedure, we made CT visualization of appendage, and during the procedure, we used only intracardiographic echo. In this picture or video, you see the procedures. After procedure, we starting with the dual antiplatelet therapy for 6 months, and ASA was indicated permanently. After 45 days, we made a control echo, and there was good position of occluder without leak or thrombus. Let's move to VT cases. Case number 9. Everybody know what is it? It is Sphere 9 catheter. We call it Affera. It's all-in-one technology with AG mapping, and it uses dual energy, pulse field, and radio frequency. We use it for 84-year-old man with dilated cardiomyopathy for arrhythmic storm. The interrogation you see here, there was 151 VT and the other parameters. We indicate focal incessant VT. Cycle length was 605 milliseconds. The focus was LVOT. And in this picture, you see there was combination of radio frequency and PF ablation. You see red points for RF and the green points for PF. And post-mapping base map was very, very wonderful. There was no inducibility of focal incessant VT. After 3 months, there was no recurrence of VT. Everything was okay, and the patient is in her hometown. And let's move to case number 10. It is the hardest case because it was about VT storm in dilated cardiomyopathy using Affera system with Pericross device. The device deploys tiny mechanical tines that physically engage and retract the pericardium. It was used for 75-year-old man. And you can see, this is the interrogation. In March 2025, there were 2 shocks and 2 ATPs, and then it was worse. In May 2025, there were 6 shocks and 11 ATPs. We see the monomorphic VT with cyclen 3040. The focus was in ferroseptal, and we ablated with combination RF and PF. This was case about endo-epi mapping, but we were only angiocardial because pericardial was adhesive. So we were not so successful, but after 3 months there was no recurrence of arrhythmia. And let me invite you for today's live case. There will be another patient with VT, and we will use Affera system Pericross device, and I think we will be more successful. Thank you for your attention and enjoy the Congress.